As you heard throughout yesterday and today's talk, the importance of transseptal importance in many of the procedures that we do is paramount. And actually, transseptal puncture had a long history since it started in 1960 by Dr. Ross, and it came out a very long journey and of development and improvement in the techniques all through this period. Initially, it was performed to just measure the left atrial pressure, which was the most accurate at that time, but the indications for that procedure evolved over time, starting from balloon mitral valvuloplasty to clipping procedure, valve-in-valve mitral and transcatheter mitral valve replacements, paravalvular leak closures, the pulmonary venous isolation procedures, tandem hearts or assist devices, and left atrial appendage closure, and many more, I think, to come. The contraindications for the procedure, the absolute ones are the presence of intra-atrial masses, either be it in the left atrial appendage or on the septum itself. However, some relative contraindications do exist, like the disruption of normal blood flow from the inferior vena cava, or just in cases of IVC ligation or congenital anomalies, distortion of normal anatomical landmarks like severe kyphoscoliosis and osteoarthritis or prior pneumonectomy. Patients who are unable to lie flat cannot undergo the procedures. Those who had severe dilatation of the aortic root because of distortion of the anatomy, those with bleeding diathesis or with very large right atria, and those who had a previous repair of the atrial septum. However, despite these relative contraindications and because of the new techniques, the success rate of the transseptal puncture in the modern era is very high, more than 95%. With tools that allow accurate localization of the puncture site. And we also have multiple approaches apart from the usual venous approach we have in special situations if we needed to. So the crucial and most important part of targeting the septum for puncture is to understand very much the anatomy, and this is a thing that I'd like to emphasize a lot on. As we can appreciate from the basic science of anatomy, the interatrial septum is basically two layers, the septum primum, which fenestrate, and then the septum secundum comes down to coalesce with the primum with the patent foramen ovale, where you have this hole in the septum secundum is the patent foramen ovale, which is actually the floor of the septum primum. The most important thing is that the septum secundum, when it forms, this is how to show you the floor of the septum secundum. When it forms a ridge, and this ridge is actually an inward invagination. So it's not a single layer; it's an inward invagination of the, if you can say, the heart muscle or the muscle of the right atrium. So the most important thing concerned with the intervention or getting a transseptal puncture, that if you didn't go through the foramen ovale, which is the floor or the part of the septum primum coalescing with the septum secundum, you actually go outside the heart. And this part is not that big. It's not like as big as the septum. It's a small part in the lower posterior part of the atria. So please be careful when you target the interatrial septum. As if you go very far posterior, very far anterior, very far superior or inferior, you are actually coming out of the heart and then back again. Sometimes into the pericardium posteriorly, sometimes in the transverse sinus anteriorly. So this is very important, keep in mind. And actually the complications that happen if you managed to go across the muscle and go to the left atrium doesn't happen immediately. They happen at the end of the procedure when you remove your sheath and then you have the whole pouring into the pericardium. And I can find no better pathology to delineate this fact apart from the lipoma of the interatrial septum. And as we all know, lipids are present outside the heart. They are in the pericardium. So when some patients in rare situations get a lipoma, you can see how thick these parts of the septum are, because this is actually not a true interatrial septum. They are invaginations of the muscle, and here you can appreciate the relation between the size of the true interatrial septum and the whole septum that we see usually on imaging, just to emphasize how important this is. I'll go to quickly through the recent puncture systems. These are the old traditional system, which is formed of a sheath, a dilator inside, and the traditional broken brow needle. But nowadays we have a lot of the sheath shapes to enhance the reach to the septum, especially in cases of large right atria. And now also we have the steerable sheaths, especially in cases of left atrial appendage closure, in cases of paravalvular leak closure, which can direct your direct your sheath toward the needed target. The broken brow needle comes in 3 curves, comes in 2 sizes for the adult and 1 size for the pediatric, and in different lengths, so it can adapt to various anatomies by selecting the proper needle. However, these needles, because they are fixed and the anatomy is variable from patient to patient for more than 30 degrees, this causes a problem. And we often adjust the curvature of the transseptal needle even by your hand before going to the shape. However, some new tools are available now, like the adjustable deflection needle, the Flex Point 1, which is a deflectable needle and not a sheath, and has a knob that when you rotate the knob, you can change inside the patient the angle or the curvature of the needle, forming both a primary and secondary angle. Just to have a quick review of the steps, this usually or traditionally you go with the wire into the innominate vein and left subclavian, and then we introduce the sheath. Then the pigtail should locate on the aortic valve to demarcate this aortic valve. You would draw on the septum just to have this dip inside the fossa, and then you target which part of the fossa you would like to have. And this depends on the target, as we will mention later, but all the targets are within the fossa. When we say superior, inferior, anterior, posterior, these are all terms inside the fossa ovalis and not inside the septum. And these are 2 completely different terminologies. So if you target here, this is superior anterior, superior posterior, inferior anterior, and inferior posterior. I usually do the puncture in the lateral view and selecting the half distance between the aortic pigtail or and the vertebral column, or 2/3 between the aortic pigtail and the posterior wall of the left atrial appendage. And as you can see here, you introduce the needle into the left atrium, and you can know exactly when you are in the left atrium by observing the pressure change between the right atrium and left atrium. Some people inject into the septum to demarcate the septum, but I don't like this because it causes some arrhythmias to start with, or you can dissect the septum and go, if you are not in the true fossa ovalis, you can dissect the septum with the injection. Some alternative techniques apart from pushing the needle is to just apply RF waves to the normal broken brow needle to help you to do passive, not active access to the left atrium. Or some new tools also exist, like the Safe Sept, which has this form of a nitinol wire, which is pre-curved, and once you go into the left atrium, the wire curves back, protecting the rest of the structures in the left atrium, and allow you to go or to follow with the sheath and the dilator. Another very famous system is the Baylis system, and it also applies the power or the energy to the needle itself, and it has a blunt end that avoids you for complete pushing. And as you can see here, just apply to the proper site, apply the energy, and you should be inside the left atrium here. Here again in the TEE, you can appreciate how thick here this part is, because this is not the true septum, and this part, and this is the true interatrial septum as we discussed. A second or a third platform is the VersaCross platform, which is actually does not have a needle, or it's only one system with a wire, the VersaCross RF wire, the steerable dilator, and the VersaCross sheath. And this is to save some equipment and some steps in the procedures. And this is the beauty of the system, as well as the wire is a pigtail shaped, and you use the same wire for access, so you don't need to go to the left subclavian. You just push the wire into the right atrium follow with your sheath and dilator, and then you adjust to the target point of the interatrial septum, apply the energy, push the wire into the left atrium, forming its pigtail, and follow with your sheath. So it saves some steps from the usual classic procedure. Of course, sometimes after we cross the septum, we need to dilate, especially with large bore or large caliper devices, and the dilatation is either done by a special dilator that is provided with the device that you are using, like here with the Inouye balloon. It's provided with a special dilator, or you can dilate with any balloon starting from 8 millimeter up to 12-14 millimeter for the larger sheaths. Echo guidance, as we have seen during the past talks, is very of a paramount importance, and you can have TE, which is of little importance. TE, as we see it, both 2D and 3D are very important when you target specific sites for left atrial appendage closure, mitral clips, leaks, PFOs, and EP procedures, especially in dilated, distorted anatomy and in complex anatomy like dextrocardia, or in cases or centers with low volume, until you build a good learning curve. And I cannot find a better example more than the need for TE apart from this one, which have severe kyphoscoliosis and with extracardiac distortion and with change of all the known anatomical landmarks. So here you really need some help from the from the TE or from echo guidance. Quick talk about the specific sites for specific procedures. This is a very large subject to speak about, but just in short, the optimal transseptal location depends on the left atrial target that you are aiming to, be it a left atrial appendage, the mitral clip, or a closure. And these are a summary of the specific sites. So you go superior, posterior for the mitral clip, the medial paravalvular leak, or for transcatheter valve in valve. You go inferior, posterior for left atrial occlusion to give a space to maneuver the sheath inside the left atrium to go to the left atrial appendage. You go superior anterior if you are aiming for transseptal PFO closure, middle to middle in atrial septostomy, and inferior in indirect annuloplasty. Two specific words about the low posterior that is used usually for the left atrial appendage closure and mitral valve in valve. Accessing the left atrium with delivery sheath with appropriate trajectory is very important to the mitral valve in valve. So the puncture site is very important, as well as the direction of the wire, and sometimes you use an apical rail for that. So you just adjust the wire both by obtaining a good septal puncture and puncturing the apex to have the rail centralized inside the procedure. A high posterior approach for the mitral clip, especially for the medial valve, we can gain that, what I prefer to call a distance rather than height. So you can go not a very bit high, but you can go a very bit posterior at some times to retain this distance from the mitral valve. So I prefer to call it a distance rather than a height from the mitral valve. This is to show you an example of transseptal for left atrial occlusion, and this is you go here in the bicaval view, you go inferior, and you go in the transverse view, you go posterior, and this is the perfect site for the left atrial appendage closure. For the sake of time, I'll skip this. I'll just to show you this intracardiac scopy of the how our equipment behave in the fossa from an animal model, and this is how the mitral clip sheath looks like inside the left atrium. So you have a huge structure in there, and this is how it looks like after the puncture. So, my dear colleagues, my take-home message for today is that transseptal puncture is a necessary skill for interventional cardiologists doing these structural procedures, and they are required targeted septal puncture to meet the needs on particular interventions, and new tools are there available in the market, and imaging and guidance of intracardiac imaging is very important in these situations. Thank you so much for your listening.